without any further ado, I'd like to go ahead and introduce today's speaker. Alexandra Muggy is the Deputy Chief Health Informatics Officer at Centers for Medicare and Medicaid Services. And with that, Alex, I'll hand it over to you.
Thanks very much, and thank you all for having me on your call today. I'd like to, give you a brief overview of the Interoperability and Patient Access Proposed Rule, and then very much looking forward to hearing some of your questions and helping answer some of those, and hopefully we'll hear more from you through our formal comment process, which I will go over at the end of this presentation on how to submit a formal comment for consideration in rulemaking. So first, I just want to give a little bit of background on what is this rule and why did we do it? So the Interoperability and Patient Access Proposed Rule is what we are calling a first phase of policies to advance interoperability in the healthcare space. It's really a unique rule in that it touches on almost every entity that CMS regulates, from health plans to clinicians to hospitals, post-acute care providers. There's a little something in there for everyone. But all with the overall focus of interoperability and patient access to their healthcare information. When we started the process of drafting this rule, we had several folks around our internal agency just asking, didn't HIPAA give patients access to their health information? Why are you doing a rule on patient access when this is already something that patients have a right to under HIPAA to receive? And the answer is that yes, while HIPAA gave patients access to their health information, they do have that right. We're seeing in a lot of places in healthcare that this is still not happening. We've heard many different reasons for why this isn't happening. Challenges with an EHR vendor, technical problems, providers and hospitals potentially information blocking or withholding information from other providers. We've even heard HIPAA as an excuse for why folks are not sharing health information with patients. And we wanted to be able to take an opportunity to set the record straight and to put some proposals out there that would help encourage the seamless flow of information. So our goal is to get to an interoperable healthcare system in which patients, providers, and payers can all exchange data seamlessly and securely amongst each other for the purpose of better care coordination and just really making better informed consumers of healthcare. There are, on your screen, we have a roadmap of the different proposals that are in this rule, kind of where they're effective and where we've come from, what some of the events were leading up to this proposed rule. I'm going to walk through the proposals. There are 5 for health plans and payers, and then there are 3 additional proposals for providers, and then there are several RFIs. So bear with me as I go through these quickly, and then we'll open it up for questions. The 5 proposals that are geared towards health plans and payers, I want to first clarify what I'm referring to when I say health plans and payers. In this proposed rule, we are talking about Medicare Advantage plans, Medicaid managed care organizations, Medicaid fee-for-service, CHIP managed care organizations, CHIP fee-for-service, and the qualified health plans under the federally facilitated exchanges. So, like I said, a little something for everyone, and the proposals here would impact about upwards of over, I believe, 85 million patients that are enrolled in these different plans. So very far-reaching in terms of access to patients. The first proposal we have here for this crew is patients' access to their health information via API. In this proposal, we are proposing a requirement for these health plans and payers to make patient claims, encounter, and lab test data, if available, available to patients through a FHIR-based API. So what we have attempted to accomplish here is to make sure that that patients have access. They can get go to their smartphone, download an app that would link to this API and really be able to see their information in whatever format they choose based on the app that they're choosing, to become better informed healthcare consumers and to make better decisions about their care. They can also use that application to share their data with, for example, their physician or another caregiver, but this really puts them in control of their health information from their health plan. The second proposal that we have for health plans and payers is in regard to provider directories. We have proposed that these health plans would make their provider directories available through a similar FHIR-based API, but that provider directories would not only be available to current enrolled patients of the health plans, but also made publicly available for prospective enrollees to check out the network of providers, and also for clinicians who would be using that information for the purposes of care coordination or referrals. The third proposal for health plans and payers is a payer-to-payer exchange proposal in which health plans would be required at the request of a patient to exchange information and aggregate that information so the patient has it all in one place. And let me give an example of this one because it's a little challenging to just describe it at that high level. So if, as proposed, this proposal were to go into effect in 2020, and I am a patient who changes health plans every year. Let's say in 2015, I was in health plan A, and 2016, I was in health plan B. I could go to my new health plan once this proposal is effective and say, I would like you to get my information from health plan A and health plan B and any other health plans I've been enrolled in the last 5 years, incorporate that data into one record so I have everything aggregated in one place, and I have a complete list of my claims information, the providers that I have seen that have billed for services. I have a list of my medication history, et cetera, all in one place. We understand that health plans currently exchange information, but specifically this proposal would be to enable patients to facilitate that exchange and to ensure that the data is aggregated in one place and follows the patient as they move throughout the healthcare system. So that is a critical piece. If a patient is moving from plan to plan, we believe they should be able to maintain their data and not lose it or leave it essentially at their prior health plan, but that it can come with them to inform their future decisions. The fourth proposal that we have here for health plans is to require health plans to join what's called a trust network. So under this proposal, it would help to better facilitate the data exchange, not just between payers, but also between payers and providers, and really just enabling that care coordination and data flow. The fifth proposal that we have for health plans and payers is really more geared specifically towards payers, and by that I mean the state Medicaid agencies and Medicare itself. So this proposal is for those dual eligible patients who are enrolled in both Medicare and Medicaid plans. What we are proposing to require is that that the payers or the states send certain enrollee enrollment information to Medicare daily for the purposes of benefit coordination. So, for example, right now, states are only required to send that information monthly. And if they send a data file to CMS on the first of the month, and a patient enrolls in Medicaid in the second of the month, for the entire month, that patient may be going to see doctors and may be getting inappropriately billed services. There'll be much confusion as to what plans they are enrolled in. By exchanging this data with states on a daily basis, we really avoid that confusion, provide a better beneficiary experience, and reduce the process of reprocessing all of those claims that would otherwise have required reprocessing. So this is really to benefit and improve the patient experience for those dual eligible beneficiaries. So I know I'm going through these quickly, and that's why we're going to have an opportunity for questions at the end, but those are the main proposals for health plans and the payers. The next set of proposals are geared towards providers, so clinicians and hospitals. We have three proposals here. One is related to the practice of information blocking, so the practice of actively withholding information from patients and other providers. This is a practice that is strongly discouraged by CMS. The Office of the National Coordinator, or ONC, also recently released a rule from the 21st Century Cures Act that discourages information blocking. So this proposal really demonstrates our alignment with the other agencies of HHS and our opposition to the practice of information blocking and really trying to discourage that among providers. So what we have proposed here is that under our Promoting Interoperabilities programs today, so formerly the Meaningful Use programs, we have attestation statements that providers have to attest to when they submit their data that say that they are not willfully information blocking, knowingly or willingly information blocking. If the provider is unable to say, I am not information blocking, or they sort of actively say that they may be participating in information blocking, we would publicly report their names on a CMS website. And again, this is in an effort to really emphasize the Department of Health and Human Services stance against the practice of information blocking and discourage providers from partaking in such practices. For the second proposal for providers, this relates to our Nppes provider directory. Over last summer, in the June timeframe, CMS updated the Nppes provider directory to accept digital endpoint contact information. So in the form of a direct address or other digital endpoint, we have now a field available where providers can populate that information. And the goal being that if all providers enter their information here, it would allow those providers to find each other in the digital space and exchange information safely and securely in an electronic format. This directory is only effective if providers make use of it and enter their digital endpoint information in the Nppes directory. To ensure that providers are encouraged to do so, we have proposed to publicly report their names on a CMS website if they have not entered their information by a particular date. So again, that should ideally facilitate better exchange of electronic information and the better flow of data between providers. The final proposal that we have for providers is really geared towards hospitals. We are proposing that as a condition of participation in Medicare, that hospitals would send an electronic notification at admission, discharge, or transfer of a patient from the hospital to that patient's care providers with whom they have an established care relationship. So if the patient is, when the patient is admitted, their doctor would be made aware of that admission. When they're discharged, the doctor would be made aware, sort of as a signal of, hey, your patient was just discharged. They may need additional support. You may want to reach out. Or if they're transferred, the providers are made aware of that as well, so that no one falls through the cracks. That's the extent of the proposals in this rule. We also have a set of RFIs in which we are requesting information on the public for future rulemaking purposes. The first is in relation to our Center for Medicare and Medicaid Innovation Models. And in this proposed rule, CMMI has stated that through their authority, they will include certain interoperability requirements in all of their models going forward. So any future models that are established will have interoperability requirements. However, because the models vary greatly in the types of requirements that they have, the types of providers that are enrolled in those models, and the purpose of the models, those interoperability requirements may not be consistent across all of the plans, but may vary based on the model type. This RFI is seeking comment on what types of requirements that might be, what that should look like, and very eager to hear public feedback on what their thoughts are on making that a reality. The second RFI that we have, we are seeking comment on the on patient matching. So it is near impossible to have a conversation about interoperability without talking about how to correctly match patients when this data is exchanged electronically between providers. When you have two records, how do you meld them together and ensure that you are doing so for the correct patient? In this RFI, we are seeking comment on what some of the best practices would be for patient matching, how to sort of expand the use of patient matching throughout the healthcare system, and ensure that it's done consistently and effectively to ensure patient safety. The third and final RFI is related to post-acute care providers. We understand that these providers have a lower adoption rate of electronic health records or health IT, and we have heard that is in part due to the fact that they were not eligible for the meaningful use program incentive. We are seeking comment on how CMS can support these post-acute care facilities in further adopting health information technology and also advancing interoperability among those post-acute care settings. So very eager to get some feedback on how the public thinks that we can make that happen to really improve the care across the care continuum. So that is the overview of the rule. Again, I know that was very quick, but I will open it up for questions in just a moment. I wanted to go quickly over some of the impacts that this rule could have for the different players in the healthcare industry. So for patients at a high level, we really believe that this will increase their access to their health information. And with this increased access, this will provide them, this will allow them to better engage in their healthcare and make more informed decisions about their care. So really making them better consumers of the healthcare market overall by giving them the resources they need to make empowered decisions. For providers, I want to stress again that this is the first phase of policies that we are putting out, and we are considering additional ways to increase interoperability among providers. The policies in this particular rule will really give providers more comprehensive data on their patients with access to claims information. They'll be able to see treatment histories, prescription drug lists, other providers in the patient's care team to really facilitate better care. This rule also has policies such as the digital endpoint and Nppes proposal, policies to increase access to data exchange between providers, so provider to provider, not just through the patient, but amongst one another for care coordination and just, again, providing better healthcare treatment overall. Thirdly, for payers, this is really a first step at engaging payers more in the interoperability and health IT space. Previous policies that CMS has carried out, such as the meaningful use or promoting interoperability programs, have really focused on clinicians and hospitals and how to engage them in health IT adoption and interoperability. And now we are expanding those policies to payers to get them involved and really complete that complete the interoperability, I'll call it a triangle between patients, providers, and payers, and ensure that they are taking part in that data sharing since there is such rich data available to payers that they have access to. This will also improve care coordination for payers with access to increased information. They'll be able to better manage the care of their enrollees, and it will therefore improve the relationship that they have with their patients. We have also seen that by engaging patients in their healthcare and having them review their own claims, it allows patients to better identify fraud or incorrect billing. We've already seen examples of this in our own Medicare fee-for-service program with our Blue Button API. And so we believe that the benefits of that will extend to the private payer market as well. Now, as I promised, I'm going to go ahead and open it up for questions. But first, I want to highlight that our official comment period opened yesterday on March 4th and continues through May 3rd. There is a link to the Federal Register documents on your screen now. If you can go there and submit a public comment. I welcome any and all questions during the Q&A process. However, I do want to remind everyone that any comments or questions that are received here are not considered official feedback and cannot be considered for final rulemaking. So if you have something that you would like us to address in the final rule, I strongly encourage you to submit a formal comment. In addition to that, there may be some questions that we are unable to answer. And so if I say that I can't answer that because we're in rulemaking, it's not because I'm trying to dodge your question, but it is simply because we cannot provide certain interpretive guidance or respond to certain questions about rulemaking. So I may direct you to the Federal Register to submit your formal comment at that time. That's it for me for talking at you. Now I'd like to open it up to any questions you may have.
Thank you so much, Alex. We're going to get started with the questions that were submitted during the registration period. The first one, TSCA has not been finalized and will likely not be will likely not be by the compliance deadline of January 1st, 2020. So what will be the standard? What does a trusted exchange network mean for the deadline if we do not have TEFCA?
Thanks for the chance to address that. We understand that the TEFCA is still in progress. There are currently several trust networks that already exist, so not necessarily exactly TEFCA, but they are trust networks that have been established and could be utilized for the purposes of meeting the requirements of this rule. And again, and we do, and sorry to expand on that, we do have a definition of what some criteria of what the trust network would need to meet in order to be considered successfully meeting this requirement. And again, there are several of those that are established and currently operating.
How will conflicts between patient rights under some state and federal laws be resolved?
We are, in this rule, we are not proposing any changes to patient rights or to privacy laws. So anything that is currently in effect will still be in effect. I want to highlight that the proposals in this rule, specifically the initial API proposals, are granting patients access to their own data. Patients own this data. It is not owned by any healthcare provider, payer, or an EHR vendor. It's the patient's data. They currently have the right to access that information and to share it with whomever they choose. So, that would not be impacted by any other state laws, privacy laws in place.
Okay, another one, and this one gets kind of complicated, but we'll see. The CMS NPRM requires the use of content and vocabulary standards at 45 CFR Part 162. What specifically is the regulation pointing to, and under what scenario or part of the regulation would that data be required?
So you're right, that one is a bit complicated, and I think, in some ways we contribute to that by doing a lot of cross-referencing in our rules, but we do that to ensure that all of these requirements are accurately stated and we don't misstate anything when we're trying to refer somewhere else. So I think we expand quite a bit on the content and the specific fire standards for the APIs in the ONC rule. So the cross-references in the CMS rule over to the ONC rule would provide a little more context to answer your question. And you should find the additional information there. But if you still have trouble finding that, we welcome you to reach out separately and we can help you track that down. Thank you.
Great answer. Now we're moving over to the questions that are being submitted in the GoTo webinar control panel, so feel free to add your questions there. The first one, how would one use the Nppes registry to find a provider's direct address, considering when simply searching for that provider, their direct address or even email address is not visible publicly at this time?
So when you, there may be reasons that some of that information was pulled down. I will just say the Nppes directory has been updated with the field to include the digital contact information, and that is actually a publicly available file. If it's not available for some reason right now, it may have been taken down for maintenance purposes or to update something. But it is typically available publicly for folks to locate those providers and to locate that information. I do want to just quickly clarify, because in the question it said email addresses. This proposal and the Nppes directory were built around accepting digital endpoints and digital contact information. So your standard email address here would not apply. Just wanted to make sure that we highlighted that. But thank you for the question.
Thanks, Alex. Next question. Can you clarify ADT for HIE? A hospital would be required to do all or one?
they would be required to do all the admission, discharge, and transfer notifications as part of the ADT standard.
Next, for ADT HIE, we're a small community rural hospital with a psychiatric facility. Many ADTs come in and go out to SNF, LTCF, special needs facilities, etc. Are there requirements set forth for those facilities that they can accept ADTs via direct, even though we are capable of sending? Any comments on this?
There are no requirements for the receiving facility, at least not as part of this rule. There are no requirements that the receiving facility be able to accept the information, but just merely that the hospital has the capability and is sending the information. There are also some limitations noted in the rule where a hospital may not be able to send these notifications under certain circumstances, and so I would highlight that you take a look at that in the rule proposal, and if you have additional questions or think that there needs to be additional clarification, that you include that in a public comment submitted through the Federal Register.
And can you define or expand on post-acute care settings, please?
So a post-acute care setting would be, like, for example, like a skilled nursing facility, even home health agencies would be included in this. Really, any facility or agency that would provide care, even long-term care facilities and others are included here. So I don't know if that's answering the person's question, but hopefully if they need additional clarifying, they can add another question to the chat box.
Thanks, Alex. And just to reassure everybody, the presentation will be emailed in PDF format to all registrants. So thank you for those questions, but please rest assured that you will be receiving the presentation in the PDF format. And keep sending your questions in. We've got another one. I'm not clear. Who will pay for these integrations, plans or providers?
If we're talking about the API builds, those would be paid for by the health plan. And there is a cost analysis in the end of the rule that would outline our assumptions around those costs and how they would be applied.
What clinical data from payer perspective is in scope? All received for operational purposes like claims and prior auth?
So for the API, we have specified in the rule that it would be any lab testing information that is available. Certainly encourage health plans to share as much clinical data as they have available for a patient, as that clinical information really aids in their decision-making and empowers them to be better consumers. But the bulk of the information that we anticipate and have called out in the rule that would be made available to patients from the plans is their claims and encounter information, which would include name of the billing provider, the cost of the care, the date of the encounter, if there are any prescription drugs included, et cetera. So anything that would be in like the in the summary of benefits, that would be fair game for this claims API, and then the additional clinical information that we have called out is the lab test results.
Next question. This one is a long one, so let me know if you need me to repeat any parts of it. If a Medicare Advantage health plan is part of an integrated delivery system and the Medicare enrollees in that plan already have full access to their medical record information via an API under meaningful use, would that be sufficient to fulfill the requirement to provide access to claims data, since the data the Medicare enrollee has access to is the actual electronic medical record and claims are not used in such integrated health system arrangement?
So on the face of it, I'm thinking the answer is no. This is a requirement for the health plans themselves to provide a patient access API, and again, it's a FHIR-based API with certain specifications that are outlined in our rule, but also, again, we point to the ONC rule for additional detail, and it would include all of the health plan's claims information. So it sounds like if that information is not available through other APIs, then no, that would not meet the requirement.
Is there a list of trusted networks as you referenced?
There is, and I'm not going to Google it right here because I know you're all looking at my screen, but but they're on the ONC, so that's healthit.gov website. You can search for the trusted networks. I believe they have a slide presentation that includes all the names of those organizations, and there are, I believe, 8 of them listed there, and I'm sure that that list is growing. So that would be a good place to start.
Is there a frequency requirement for the directory digital updates?
So just to make sure that I fully answer this question, because we do have a couple of directories in here, and it sounds like you're talking about the digital directory, which would be Nppes. There is not a frequency requirement there. We did say in the rule, though, that we would be publicly reporting providers who don't have their information populated after a certain point in time. Just to be also clear about just how kind of the CMS directories work overall for PACOS, which is another registration system that we have here at CMS. Providers are required to update their information within 30 days of a change in order for them to receive payment from Medicare. If Nppes has a separate requirement, it's not addressed in this rule, and I'm not familiar with it, but I would refer you to the Nppes website there just to make sure that that you're getting all the appropriate information. That's a good question. Thank you.
Thanks, Alex. Next question. Are there any rules that you could reference or direct us to that provide any regulations that push EHR vendors to share their direct addresses for providers?
Not any rules or regulations that I can point you to. However, EHR vendors should be able to provide the clinician or facility with that information, to their clients. So I recommend working with your EHR vendor to get that. It is also possible to get a direct address outside of the EHR and obtain that information without your EHR vendor. So there are multiple ways of meeting this requirement.
How will the directory address providers who have multiple direct email addresses for their facilities? Will they all be listed?
So that's a good question, and it is not outlined in the rule. I don't know if there may be guidance on the Nppes website itself, although I'm not sure that I have seen that in particular. I don't want to misstate, but I don't think that I have seen that. So I recommend and suggest that you submit a comment to the Federal Register so that we can address that further in the final rule.
How does patient matching play into these goals?
So really patient matching and interoperability just go hand in hand, making sure that you have the correct patient information and you're blending those records appropriately is critical for patient safety. And so this is not something that we wanted to ignore from the rule and wanted to make sure that we addressed it thoroughly. So it's discussed both in the background section and in the RFI. In terms of the proposals here, while the health plan proposals provide information directly to the patient, so there's not a patient matching requirement there necessarily, anywhere that provider to provider or even patient to provider in terms of blending that health information into one record would require accurate patient matching to ensure that the right information is being reflected when a patient is receiving care. Again, this is a patient safety issue, and it is a critical issue, and it is something that has been a considerable barrier to interoperability for quite a long time. So we wanted to make sure that it was addressed. But any information sharing will always link back to patient matching and correct identity.
Thanks. For a health plan, is the intent that claims payment information pre-authorization is available via the technologies of XML or JSON to be consumed by the HL7 API?
Excuse me. That is not specifically addressed in the rule. What we address is the FHIR standard for the API. The ONC rule goes into a bit more detail in terms of the resources used, et cetera. So certainly that's a good resource to look at for additional details on the API in general. We did not specify in the rule, however, the other formats, and so I suggest submitting a comment so we can address that in the final rule.
Thanks, Alex. This is the last question that we have typed in right now, so if you have any more questions, make sure and get them in. As more coming in, thanks, guys. As a development company for health plans, are we considered an API technology supplier as defined by the rule?
Can you read that one more time?
Yep. As a development company for health plans, are we considered an API technology supplier as defined by the rule?
It would depend on your relationship with the health plan, so I think the answer is maybe. But yeah, it depends on how you set that up with the health plan and how you're implementing or building in the API.
Are there any regulations that require the provider to act upon the electronic notification of their patient's admission, discharge, or transfer?
None that we have proposed in this rule. But thanks for asking. That's a great question.
And that's it for, nope, just kidding. Another one came in. Sorry. Regarding the hospital requirement to send electronic notifications to primary care providers, will this be done through EHRs, bypassing HIEs who are already providing this functionality to hospitals?
We do not specify how the message needs to be sent, only that it needs to be sent. So I wouldn't say that that's bypassing or directing any particular technology or entity. But if you'd like further clarification on that or have additional questions, again, I suggest that you submit a formal comment to the Federal Register.
Can you distribute a list of trusted networks with the slides? I can't find it on the ONC site.
Sure, yeah, we can. I'll email that over so that that can be sent out with the slide deck presentation.
Thank you so much. I'm sure everybody will appreciate that. For HIE connections, will the standards need to be supported?
Not sure if I know what that question is asking, so I'm not sure that I would be able to provide the right answer. Can you read it one more time?
So it says verbatim, for HIE connections, will IHE standards need to be supported?
I think that falls outside of the scope of this rule. So I'm not sure that I have an answer to that one. I apologize.
No problem. And just my curiosity, is there any way that you would advise or suggest anywhere where we could provide more education for the industry, or any gaps in education that you see that you guys would appreciate us stepping in to provide more information and support?
I'm sure that the answer is yes. We always appreciate any help that we can get in spreading awareness and furthering education. I know certainly through some of the questions we've received on these webinars, I know that there are a few places where it's clear that additional education would be helpful, particularly around, and even some of the questions on this call have alluded to questions about digital endpoints and direct messaging and how that can be used for health information exchange. We really like to talk about this proposal as eliminating the need for a fax machine. So ideally, that's one byproduct of something like this. If you don't mind, we'll take that back, think about it, and we may come back to you with an extensive list of ways that would help, but we really, truly appreciate the offer.
Well, we are here for anything you need, and we love working with y'all, so anything we can do to help out and provide more education and support for the industry, we are absolutely thrilled to do so. That's all of the questions that have come in. Would you like to wrap up with any comments, Alex?
I want to thank you again for having us here today and for the offer to help further the education. The proposals in this rule are very far-reaching, and again, really the end goal of all of this interoperability effort is to integrate all the health plan players so they're able to exchange information safely and securely for the betterment of patient care and care coordination. So just any comments that you have on the rule, we welcome all of them, no matter how small. We truly do read every single one of the comments we receive, and we care very deeply about this rule. Some of us probably take it a little too personally because we all have our own experiences with interoperability and data access that are challenging. And so we really want this to be as effective as possible, and any input you can provide will certainly aid us in getting there. So thank you again, and I look forward to reading your comments.
Well, thank you so much, Alex, for being with us today and answering all of these difficult questions. We appreciate your time and all the work y'all are doing on this. It's fantastic. So thank you again for being with us, and thank you for everybody that joined us for today's webinar. I'll be following up with an email with the slide deck as well as the other documents that we talked about and the link to the recorded webinar. So thank you, everybody, again, and enjoy the rest of your day.